Good morning, this is Georgia Raisman and the Monday Scoop. And today I'm here with John Fahy, a physical therapist, a doctorate of physical therapy, and we're going to talk about the importance of physical therapy to people over age 55, under what circumstances you need it, when you should stop doing it, when you should start doing it, and why, and some of the myths and preconceptions that people might have about that. So John, thank you so much for joining me.
It's my pleasure,
that you came
Georgia.
in today. Appreciate it.
Thank you.
So you've got a doctorate in physical therapy. A lot of people don't know that you need that much education. So how did you come to be interested in that field, and what's involved in becoming a physical therapist?
I became interested in physical therapy through fitness. I started out as a personal trainer, and from that I found that some of the best education in learning about the human body and the way it moves and exercise was in physical therapy, so I decided to pursue that as a profession. And at the time, most of the master's programs were transitioning to clinical doctorate programs, and so I felt that it was important to get into one of those programs because it was becoming the standard, and now it is the standard of education. So all the programs now are Doctorate of Physical Therapy.
And yours
programs.
was, you did yours at Columbia in association with its College of Physicians and Surgeons. So
That's right.
It's really a medical specialty.
Yeah,
And a lot of your a lot of your training was with the physicians in their early stage of their training.
Yeah, it's a multidisciplinary, so physical therapists have to be able to work in many different types of settings, from hospitals to long-term rehab facilities, outpatient facilities. So we have to be able to work in any of those environments with patients from all different kinds of diagnoses.
So the training goes to really what's wrong with the person's physical body on a molecular and biological and medical level, not just as a trainer, a personal trainer might know it. Which is
right. So the background is, the science background is fairly intensive, and we have to have all of the basic sciences on board. So chemistry and biology, physiology, anatomy. So it's a lot of training.
Mm-hmm. And when you started doing it, first off, I mean, people come to you for immediate relief, for long. I mean, what are the circumstances under which people are referred to physical therapists?
It's become quite common to be referred to physical therapy now. It's become the go-to conservative management option for many things. I'm talking about outpatient physical therapy, which is primarily orthopedic, and so anything you can imagine across the age spectrum that is orthopedic in nature, we'll deal with. And in terms of people over 55, that tends to be a lot of anything from just sprains and strains from regular normal daily activities to more chronic conditions like arthritis in its various stages in any of the joints you can imagine in the body. So
if somebody injured themselves, would they just think, I need a physical therapist, or do people come via physicians only, or how is it self-referred or physician referred?
It's still mostly physician referred. So if someone has an ache or a pain, they may go see their primary physician first. Some people will access a specialist like an orthopedic surgeon as their first point of contact, and then they may have some diagnostics at that point, x-rays or in some cases more advanced imaging like MRI. And then if they feel it's the kind of thing that should be managed conservatively, then they'll be referred to physical therapy. And at that point, that's usually when that person contacts our office for an appointment.
Mm-hmm. So when you say conservative management, that means doing something short of going out and having surgery or doing something that to try to help the immediate situation, the immediate problem, without drugs or surgery or something more.
Right. So
dramatic.
I usually consider conservative management to be things that are minimally invasive. So when it comes to orthopedic conditions, that could be pain medications like anti-inflammatories, either over-the-counter medications or prescription versions of those, which are stronger. On occasion, more powerful pain medications like muscle relaxants or opioid pain medications. And physical therapy or non-aggressive interventional kind of therapies like acupuncture some people will try, or physical therapy, chiropractic care. Those are all in the realm of conservative management options. And then it can become more aggressive from there. And so those are the things that are maybe some kind of injection where you're, at some risk of, developing a problem from that, like cortisone injections, epidural injections. Those are somewhat more invasive. And then ultimately the most invasive or the most aggressive kind of treatment would be surgery. So I tend to put them in those three categories.
So when you were talking initially about, when you mentioned pain management, I mean, these days that's in the news every single day, all these issues about opioids. And how would physical therapy help people address pain issues to a point that they might not need an opioid or a pain drug?
Right. So that, our primary goal is to try to solve someone's problem through physical activity and exercise, and many issues can be resolved just with that alone. And so when someone comes in, if they're in acute pain and maybe they're already taking a pain medication, we may start with very gentle exercises, range of motion, gentle hands-on techniques where we're moving a limb, or maybe we're doing some massage, applying modalities like ice or heat, electrical stimulation, which can temporarily alleviate pain. So those are the kind of things we would do if someone's in a lot of pain. For people who have more chronic type issues like moderate or severe arthritis, then we're giving them strategies to try to manage that condition, usually in conjunction with some kind of medication like a non-steroidal anti-inflammatory.
So if you saw somebody who had an acute pain in, I don't know, a shoulder or a joint or something, and you help them through the acute elements, acute stage of it, you would do that for some number of times a week, and then hopefully get them to the stage where they could be sent home with exercises that they could do that would make the pain go down over a period of time?
It depends on the patient presentation, but we may give them something to do right away, because especially for post-operative conditions, like if somebody's had a knee replacement or something like that, we want them moving and working that joint immediately. So we would give them exercises that are appropriate for where they are after that surgery, and we would want them doing a lot at home, because that's something that is in a critical phase and would need to be addressed right away. For other people, we may want to see kind of how they're going to respond to some of the things we're giving them to do first before we give them exercises to do at home. And so it really depends on the patient and how they're presenting to us at the time. So
do you see people? You see people post-operatively. That's the people who've had the knee or the hip or whatever replaced. And then you see people who have chronic issues. But what about somebody who just fell down a set of stairs and broke something, and they're otherwise in healthy condition, and they need to have something immediate addressed, and then you give them some immediate exercises to do, and then what?
Right, so there's a continuum of care for something like that. If somebody injured themselves and broke something, then they would need to access the healthcare system immediately through the emergency room or an orthopedic physician, and have that injury evaluated to make sure there was no fracture or no major trauma that would require a surgery or something like that. And then they're usually going to be referred to us, and then we would evaluate their needs at that point. If it's still acute, meaning a high level of pain, swelling, warmth in the area, then we would treat it accordingly with ice, gentle range of motion exercises. And then as they recover, if there are still strength or range of motion limitations, then our program would become more aggressive at trying to address that and normalize those impairments, so that they would be able to return to full function.
So do you find that people are responsive and responsible? I mean, do they keep coming back, or do people look for immediate improvement, and if they don't get it, they stop doing PT? I mean, what's patient response to?
Both of those things happen. So what I find is that tends to be related a lot to age and where people are in their lives. People who are retired have more time usually to come, and they make it part of their routine for that 6 or 8 weeks or whatever. They're coming 2 or 3 times a week on a regular schedule. People who are working and have families and don't have a lot of time sometimes will be less frequent, and sometimes they really want just to have the information and have the exercises and go on their way. And both of those things are fine for me. I'm always trying to figure out what's going to work best for someone and help them in the way that they need it. I don't try to push any particular agenda, but I usually do explain to people that with physical therapy, what they put into it is what they'll get out of it, because you really have to be committed to doing these exercises, not just in our office, but at home, and the things that we're giving you to do, to expect that it will be helpful. So. Can
people replicate what you do in the office at home for the most part? I mean, you don't use special equipment or anything that's...
Yeah, the goal is always to make home exercise programs something that people can do without equipment. Or with minimal equipment usually that we can supply. So we store exercise bands and things like that we can provide people. And the goal is always to make it as easy as possible to do and as straightforward, because if you hand somebody a paper with 16 exercises on it in little boxes, highly unlikely they're going to do that. So for the home program, we're trying to focus in on the few things that are the most important and try to get people to do those things frequently, so that they're reinforcing at home what we're doing in the office.
Because all of this stuff seems very incremental. I mean, for people who want to see that they've gotten better 3 days later or a week later, that doesn't seem to be what happens, right?
That's a great point. I have to tell people frequently that they really need to commit to this. And most people, if you ask them, well, how do you feel about surgery? And they'll say, well, I don't want surgery. Okay, well, if you don't want surgery, then this approach frequently will take time, especially for chronic problems, because the human body doesn't respond immediately to exercise. Any kind of exercise you do, whether it's something you're just trying to do to improve your fitness or improve performance in something, it takes time. You're not able to go and run a 5K after having not run for years. You have to build that up. It's the same thing with physical therapy and injuries that people have or chronic problems that they have. It's going to take time for those exercises to be effective, and that those programs need to be progressive. So it can't just be, I give you these exercises and that's it. Usually there needs to be a progression from more basic exercises to more challenging exercises, so that the body can continue to respond.
If they came for just 3 times a week, given that it has to take time anyway, if people come for just 3 times a week and do these say the basic level A to get to level F, is there, you can really see improvement from week to week if they came 3 times a week and did level A, and then in week 2 they did level A plus? It seems like it's awfully slow. And people must get very impatient with not even getting to level C when they're really aiming at F.
It really depends on what it is, and I'll usually tell people, because I don't, you want to give patients something to look forward to. So on the first visit, depending on what it is, I'll say, we really want to see some improvement in a couple of weeks, 2 or 3 weeks.
That's good.
Usually people are going to see improvements in mobility, maybe the level of pain that they have. Those are the first things that will get better, because if something's tight or somebody's guarding a joint and not using it, frequently things will start to get better more quickly once they just start to use the limb again.
So you have to help them work through the pain of using that joint?
Yeah, and so from there, if you can see some incremental improvement after a couple of weeks or some modest improvement, then you tend to buy in to the process a little more, and it's easier to say, well, your pain level's down a few points, the range of motion's improved, maybe you're sleeping better at night, not waking up as much from pain. Then those are the things that you as a patient can hang on to continue to work through this process and have a full recovery. But not everybody is going to have a full recovery. Some things, especially as we age, there's only so much that anyone can do, especially with arthritic conditions. That's something that's progressively worsening over time, and so it's really about management. And people,
I don't know very much about arthritis. Tell me why that is something that worsens over time.
Because it's as joints start to degenerate, and I should point out that with the aging process, degeneration in joints is a normal process of aging. Mm-hmm. It's really a matter of degree. So if someone is having a lot of pain and recurrent swelling, let's say in a knee from arthritis, there are interventions that will help that at every phase of that. And the reason that it worsens over time is because arthritis is really a degeneration of the cartilage in the joint that covers the ends of the bones. It allows the bones to move smoothly across each other. And over time, because that cartilage doesn't have an ability to heal itself, it can wear away. And the bone underneath, because it's very active, bone is actually able to repair itself. It has a great blood supply, lots of cells. It starts to take over, and so it will kind of be exposed in the joint spaces. That's where people talk about bone on bone. It can start to grow out of the joint, and you can see bone spurs on x-rays. And so there's a number of things that are going on there, but that process starts to feed into itself over time because the bone is so active, it just kind of takes over. And at the point where it's severe, there's not much cartilage left. The joints don't move very well.
And bones hitting each other is more painful.
Exactly, yeah. And that's where usually someone would be probably considering a joint replacement.
So that when you're dealing with people with physical therapy, with people with arthritis, then what do you try to help them with as this progresses?
So depending on the stage that they're at, if it's mild, moderate, or severe, if it's mild, then usually exercise programs to strengthen the muscles around those joints, restore mobility if they've kind of not been using it very much and it's gotten tight. Some of those things can cause their own kind of pain. So with mild to moderate conditions, it's about conservative management, perhaps taking an anti-inflammatory for a couple of weeks to calm down acute exacerbations where there's swelling and pain, and just trying to maintain the mobility and strength around that joint. As it becomes more moderate and the level of pain and exacerbations is more recurrent, then there's some more aggressive interventions like steroid injections into the joint or joint fluid injections in the case of knees, where they can try to, as a stopgap between conservative measures and joint replacement surgery. Once it's severe, usually if somebody comes in with severe arthritis and they're saying they don't want surgery and nothing else has really helped, I'll be very honest with them and say that we're probably not going to be very successful. And I think it's important to be honest with patients about what's possible with physical therapy.
My sister had a knee replacement when it was, as you said, bone on bone. And it's interesting because the amount of exercises that she needed to do beforehand to get ready and after to keep moving with it, and the amount of physical therapy that was required afterwards. But I read recently that these joint replacements are, although they were originally said to last only 10 or 15 years, have been in studies shown to last 20, 25 years and longer. They're very, very secure. When you finally have them, they last quite a long time.
Yeah,
and it's really transformative for people.
It can be, yeah. It can really restore function, and it depends really on what people are doing with these replacements. Some people are going out and jogging and skiing and doing that, so that's going to wear that replacement down faster. But yeah, for most people where they're just wanting to be able to walk again and do some regular exercise in the gym, basic ADLs, activities of daily living, 20 plus years is kind of the standard now.
Well, that's excellent.
And it's, the process is challenging. It's difficult surgery to recover from, but the vast majority of people feel much, much better afterwards.
That's what I hear. So what do people what do people do by way of payment? Does insurance cover physical therapy visits? And how does that?
That's a loaded question. Most insurance companies will cover physical therapy services, and when it comes to payment, that can run the gamut, and that's a whole other discussion in terms of how insurance companies reimburse for physical therapy and the patient's responsibility, whether it be a co-payment or a co-insurance, if they have a deductible before the insurance kicks in. All of those things are in play in terms of payment. Increasingly, physical therapy clinics are not accepting insurance, or they're taking very few plans that are the higher reimbursing plans. Our office, we accept pretty much every kind of insurance that's available to people in the area, and our reimbursement could range from a paltry $20 a visit to maybe 70, 75, 80, something like that. And so it depends on the insurance company, the company's willingness to accept a range of payments and really not have much control over the reimbursement. But increasingly, physical therapy facilities aren't taking insurance.
It's interesting. They're just making the patient deal with the insurance issue rather than you. What about Medicare? Do you know how it's dealt with under Medicare?
Yeah. So if a facility accepts Medicare, Medicare has some requirements. You have to have a prescription from the physician. We have to do our evaluation and write up a plan of care, and that has to have specific information in it. And then we submit that plan of care to the physician, and he or she signs it. And those are the requirements for us. And then we bill Medicare. Medicare is really kind of like almost like an honor system. So they'll pay, but if they decide to audit you and you don't have all of those things in place properly, then they could ask for their money back and institute penalties and things like that. So it's important for us to understand, physical therapists and our administrative staff to understand the requirements for Medicare if we accept it, and make sure that we're doing all of those things. In terms of the benefit itself, things are frequently changing with that. A couple of years ago, they got rid of what they called the doc fix, was that every year reimbursements to physicians and practitioners who take Medicare was supposed to, the reimbursements were going to change on a set schedule, and they basically got rid of that. So for physical therapists, there was a monetary cap per year. It was about $2,000 per year that someone could use their Medicare benefit for physical therapy, and they kept instituting an exemption process for that. Now much of that is gone, but
it doesn't seem like a very practical way of approaching it. That you should have to have a monetary benefit. It's entirely dependent on what the condition is that you're treating.
Right, and that was one of the big complaints about that, was that if a patient had used up all of their benefits, say, for an acute injury, and then a few months later had some other problem so that was the issue, and that's been resolved. But I would say that based on that, there's definitely, it's ripe for abuse. And so that's always a concern that people would abuse the benefit.
So there's a kind of a pace and a metric for how well you're doing with any given patient. I guess with Medicare you've got this plan, so you would know when you achieve that plan. But for general patients, there's a way that you know that you've gotten to a certain level, whether it's range of motion or level of pain.
It's highly variable, again, because it really depends on the patient. But for every patient, we do an evaluation, and we write goals, things that we're hoping to achieve as therapists, and we usually want to have obviously some of the patient's goals in there as well. They're the most important, what they want to achieve. And so, we're developing our plans to work towards that. So we develop plans of care for every patient, and we try to make that as specific as we can to what they need. But ultimately, the goal, I think, for me as a physical therapist is to empower patients to take care of themselves. It's certainly good to come in a couple times a week and do that consistently, but ultimately our goal should be to give patients the education, the exercises that they need to manage that problem on their own. And
to give them the confidence that they can manage it on their own.
Exactly.
And that what you have brought them to so far has gotten them to the point that they can do this now on their own, and they're going to improve as a result.
Right. Yeah. And for many things, there's no silver bullet. It's I think in our society we assume that there's going to be a quick fix for everything, but we all know that doesn't exist. But there's plenty of that out there. And so I think for my part, just to try to encourage people to to really buy into the process and be patient.
Buy into gradualism. So that's really the takeaway, right? That it's not, there's no quick fix.
In many cases, but for some things, yeah, they improve very quickly. But when we're talking about older patients, 55 plus, the reality is that the body is aging, and so there are limitations to what can be accomplished in any area of medicine and surgery. So I think it's important to be realistic as well about the fact that as humans we're going to age, and we're not going to be able to do all the things that we did as younger people.
Well, on that cheery note,
I don't not to say that you can't be as active as you want to be, but at every stage in life things are going to change a little bit, and I think being realistic about that and being proactive is good too.
Right.
And one of the things that physical therapists can do is provide preventive strategies as well. So you don't necessarily have to go see a therapist when you're having a problem. You can go see them if you want to try to prevent problems as well. So if you're an older person who's athletic and playing a sport, you could certainly go see a therapist for a few visits and talk about ways to prevent injuries in that activity.
That is a really important fact, and I think that's the takeaway. I mean, at worst, go to a physical therapist and say, I really love golf, tennis, whatever it is I'm doing, soccer, and I want to keep doing this without injuring myself.
And we see
And
the same things.
What do I do to make sure I don't hurt myself?
Over and over again, we see the same problems with different types of sports, and usually after the fact, and a lot of the things that would be preventative for that are what we're giving them then. So,
well, that's really good. I mean, that's very important to know. I had no idea about that.
And I should also mention, if you have a minute, is that in one of the reasons that they went to this doctorate level of training is so that patients could access physical therapists directly. And so you can come see a physical therapist in the state of New York without a prescription. And so, that would be an opportunity if you know that you're involved in a sport and maybe you're interested in preventing an injury, you could go see a therapist about that. And it might, you may have to pay out of pocket a little bit or something, but a couple of $100 maybe up front could be worth, a lot of prevention by getting those exercises and those warm-up strategies and so forth from a qualified professional.
That is so important.
Well beforehand, yeah.
That is so important. That's very, very helpful. That's really helpful. Well, thank you so much, John. This has
my
really
pleasure.
been wonderful. Thanks.
Yes, thanks for having me.
I learned all sorts of stuff. Thank you so much for joining me with the Monday Scoop, and tune in next week for some more.